Hey guys, so this is the NCLEX-RN 2018 ATI Comprehensive Review. In this video, we're going to be talking about pharmacology. So this is section 4, and this is part 8, because it's going to be divided into 2 or 3 videos. So here are the calculations and conversions that you need to know to solve the dosage questions. So it's kind of self-explanatory. I would just pause this video and take a picture. I'll just highlight a few stuff that you should memorize. You could memorize this whole list. I don't think you need to. I would know the temperature conversions from Celsius to Fahrenheit and from Fahrenheit to Celsius. I would also know how to convert from milliliters to liters and from mg to mcg, and also from kilograms to pound. And of course you have to know the calculations for IV, just memorize that formula, and the calculations for dosage. So here are some medication concepts that you should know. They're very basic. Interaction is basically when one medication alters the effect of another. Adverse reaction is a negative effect of a medication. It does not have to be dangerous. In pregnancy and breastfeeding, a lot of medications are bad. In pregnancy, they're called adrenergic, and with breastfeeding, you want to breastfeed before taking the medication. So with children, they get toxic level quicker because of their size, age, maturity. In older adults, they have age-related changes, so they also get toxic quicker. They have more side effects. They have a higher risk of other stuff. You want to assess with everyone for allergies, adverse reactions, what medication they're taking out to see if it's going to react, and their status, like they're healthy and stuff like that. And you should just memorize this because you're going to have to know that. You should always follow the 6 rights of medication. It's the right patient, drug, dose, route, time, documentation. You can memorize it like P, D, D, R, T, M. So these are some concepts for labs and pharmacology. So the peak level is the highest concentration. The opposite is a trough level. It's the lowest concentration. It's usually going to occur 15 minutes before giving the next dose. The half-life is the time required for the body to decrease the medication level by half. Cultures and sensitivity. So cultures, you're going to take that to detect the pathogen in a specimen collection. If there is a pathogen, then you're going to do a sensitivity to identify which antibiotic you need. If you cannot wait for culture and sensitivity, and then the doctor is going to order a broad spectrum antibiotics until you do the culture and sensitivity, and then you're going to be able to know which specific antibiotic to use. IV medication. It is given through an intravenous catheter. It can either be a peripheral or central venous access. These are some rules. Never give medication through the same tubing as used for blood. And also you should have standard precautions, so you don't need sterile gloves or anything. You should infuse the fluids within 24 hours of obtaining it and discard unused portions. Just a side point, central venous catheters could include PICC, which is a peripheral inserted central catheter, or a non-tunneled percutaneous central venous catheter, or a tunneled or an implanted port. IV infusion complications. So this slide is important. The first one is infiltration. It's when IV fluid escapes into the tissue. So you're going to stop the infusion, you're going to take the catheter out, you're going to do a cold compress, you're going to elevate, and you're going to insert a new catheter in the opposite extremity, not in the same one you just took it out from. The next one is extravasation. It's basically when a toxic drug like chemotherapy, it leaks onto the vein and the skin, and it causes a chemical reaction. So what you're going to do is you're going to stop the infusion, you're going to discontinue giving it, you're going to aspirate the drug as much as you could, you're going to put a cold compress, and you're going to document your findings. The next one is phlebitis, and it has the wording itis, so it's an inflammation. It's an inflammation of the vein. Thrombophlebitis is the same exact thing, just it's inflammation of the vein, but it involves a clot. So what you're going to do for this is you're going to stop the infusion, you're going to remove the IV, you're going to put heat on it, you're going to insert a new IV in the opposite extremity. The next thing is a hematoma. It's leakage of blood from the vessel. You're going to remove the IV, apply pressure if there's bleeding. And then the last thing is a catheter embolus. It's a piece of catheter that breaks away and travels through the circulatory system. Immediately apply a tourniquet high in the extremities to limit venous blood flow. And you're going to be prepared to remove it via x-ray. A common thing that you're going to see with all these is that basically you're going to stop the medication right away, and you're going to take out the catheter, and you're going to insert a new catheter in the opposite extremity. And usually you're going to put cold or heat on it depending on the complication. Here are some central venous catheter complications. The first one is a pneumothorax. A pneumothorax is a collapsed lungs. It could happen when you insert the central venous catheter. Treatment for this is you're supposed to give oxygen. You're going to help provide chest tube administration. The next one is ear embolism. It's when air enters the vein or artery. A treatment for this is to place in the left lateral Trendelenburg position, and you're going to give O2. The next one is lumen collection. I've never seen that in NCLEX yet, so I'm going to skip that. And the next one is a bloodstream infection. So it's important to maintain sterility, and you're going to want to change the entire infusion system if that happens, and tell your doctor, obtain cultures, and give antibiotics. Here are some complications with the PICC line, which is a peripheral inserted central venous catheter. The first one is the catheter occlusion. So you're going to want to reposition the arm, you're going to want to prevent any kinks, you want to confirm that there's blood return, you want to flush the catheter in between medications, and you want to give antithrombolytics. The next one is a catheter dislodged. So you're going to want to assess that as blood return just like before, and if there's any discomfort in the jaw, chest, ear, then you want to tell the healthcare provider because it could mean that it dislodged. The next one is phlebitis like we had before, and just like we said before, you're going to apply heat and you're going to stop if it doesn't help. The next one is a catheter embolism. Just like we said before, you're going to secure the catheters and you're not going to pull on it, and you're going to want to remove it safely. The next one is infection, just like before. Also, you're going to use aseptic technique. You're going to keep the dressing clean and dry, and you're going to report immediate signs of infection. TPN. TPN is a total parental nutrition. It's basically food that is given through the IV instead of the GI tract for someone who cannot have it through the GI tract. It's a hypertonic solution. It contains electrolytes, the proteins, the glucose, the everything. It's made according to the patient's need. It's given through the central venous catheter like a PICC line, subclavian, internal jugular vein, etc. So these are the steps. First of all, you want to verify the prescription with another nurse nearby. You want to give it via infusion pump. You want to monitor the weight daily. That's important, the weight. You want to monitor the INOs, the glucose. You want to take the glucose every 4 to 6 hours. You want to look for signs of infection. You also want to change the dressing every 48 to 72 hours. You want to change the IV tubings and fluids every 24 hours. Note, if TPN is not available, if you run out of it or for some reason it's not available right now, you want to give 10% dextrose in water. The reason why we do this is to prevent hypoglycemia. So with TPN, one thing you want to watch out for is hypoglycemia. Antidotes. So these are reversal agents in case you overdosed on any of these medications. So first of all, acetaminophen, which is Tylenol. If you overdose, it causes liver damage. So the reversal agents is acetylcysteine, which is a cough medication, but it prevents liver damage. A hint to remember this is A and A. They both start with A. And also think of A, number 1, which is like A is like always the first one. So acetaminophen is always the first medication you turn to if you're not feeling good. The next one is benzodiazepine, and the reversal agent for that is flumazenil. A hint to remember this is to think of the flu. The flu is everywhere, and benzodiazepines are taken by everyone, unfortunately, to decrease anxiety, etc. Next one is cyanide poisoning. The reversal agent is methyl blue. Hint to remember this is that cyanide, it could be a pale blue color at room temperature. So think blue, methyl blue, cyanide. The next one is digitalis, which is digoxin. They both start with D's and they both sound alike. The next one is heparin or enoxaparin, and the antidote is protamine sulfate. And to remember this is think pro. What are all hospitals pro? All hospitals are pro preventing DVT, so they give everyone heparin. Heparin prevents clots from forming, and protamine sulfate is given when there's too much bleeding. Iron, the antidote for that is deferoxamide. Think def and I from iron. So when it comes to I, like me, people are deaf. They won't hear their own faults. So think deaf, I, what are you deaf to? Hearing your own faults. Lead, the antidote is sucremare. So the next one is magnesium sulfate and calcium gluconate. I think you remember that these two go together, because if you look at too little magnesium, then you have hyperactive DTRs and CNS changes, and the same exact thing with too little calcium. You're going to have muscle twitching, CNS changes, etc. The next one is narcotics. The reversal agent for that is naloxone. A hint to remember this is that they both start with N. Think of no, you do not want to be taking narcotics. The next one is warfarin, and the antidote to that is idonadione, which is vitamin K. Just think vitamin K. Therapeutic drug levels. So digoxin is 0.8 to 2, gentamicin, I never really saw that one, but 5 to 10. Lithium, you have to know, 0.4 to 1.4. Magnesium sulfite, 4.8. There could be many more, but these are the only ones I've ever seen. So I would just focus on digoxin, lithium, and mag sulfate. So here are common drug class suffixes. So these are the endings that they all have in common. A lot of them are cardiac medications. I would just pause this. I'm not going to read through all of them. Pause this and write this down or remember this. Like some of them, ACE inhibitors all end in pril, beta blockers all end in ol, thrombolytics end in ace. Just remember these. It's easier to group them together just knowing these endings. Okay, so we're going to start with the cardiovascular medications. So here are just some groups. So antihypertensive, ACE inhibitors, calcium channel blockers, alpha adrenergic blockers, centrally acting alpha agonists, beta blockers, vasodilators. These are all to treat heart conditions. Consideration with all of them, you have to remember this. You want to assess the weight, vitals, hydration, and blood pressure, standing, sitting, and laying down. You want to assess the renal function and coagulations. You want to take the medication at the same time every day, You don't want to go in hot tubs or saunas. You don't want to stop them abruptly, and you want to prevent orthostatic hypertension. That's with all the cardiac medication. So ACE and ARB. ACE stands for angiotensin converting enzyme, and ARB stands for angiotensin receptor blockers. So angiotensin 2 is a vasoconstrictor. It increases blood pressure. So what ACE and ARB both do is that they both stop the action of angiotensin 2. They both do it at different points, but the end result is that they're stopping the angiotensin 2 from vasoconstricting. So ACE, they all end in pril, as you could see, captopril, enalapril, lisinopril, etc. ARB, they all end in sartan, losartan, valsartan, etc. So the side effects with both of these are angioedema, which if someone has that, you would give them epinephrine, and hypotension, which hypertension is for all blood pressures medications. So just think angioedema when you're talking about ACE and ARB. And with ACE specifically, it's a non-productive cough. So if a patient has a non-productive cough and it's bothering them, then you give them an ARB instead. It does the same thing, just without the cough. And another point, don't take in pregnancy. And like we said before, with all blood pressure medications, you want to monitor the blood pressure, the hypotension. And so if you're giving another diuretic, which could also cause hypertension, you want to be careful with that. The calcium channel blockers. So there are two groups. I'm not going to go into their groups, but basically the first one is nifedipine, amlodipine, and the second group includes verapamil and diltiazem, which could also be used for arrhythmias. So basically what calcium channel blockers are, they do not allow calcium into the heart. It slows the heart rate because the heart is a muscle and calcium helps it contract. Contraindications for calcium channel blockers are patients with heart failure, heart block, and bradycardia, because if your heart's not working and slowing it, it's not going to help. Also, you should not have it with grapefruit juice. It causes a toxic effect. Some side effects are constipation, reflex tachycardia, which is basically when you lower the blood pressure a lot, sometimes the body could compensate and make it tachycardia, peripheral edema, and toxicity. Just a point, you want to give the IV injection over 2 and 3 minutes, and don't discontinue this abruptly. Alpha adrenergic blockers. So what these do is that they relax certain muscles and help keep blood vessels open. Some examples are prazosin and doxazosin. Some side effects like regular blood pressure is fainting and dizziness. You should know that other hypertensive drugs are going to increase the risk for hypertension, not only for this drug, for every other blood pressure drug. And you want to know with doxazosin in specific, you should not be taking it with NSAIDs. Also take these medications at bedtime because of hypertension, and you want to tell your doctor if you're taking any over-the-counter drugs. Essentially acting alpha-2 agonists, what they do is that they prevent the brain from sending signals to nervous system to speed up the heart rate. Examples are clonidine, guanfacine, and methyldopa. Some side effects, so because they're affecting the CNS system, you're going to have adrenergic and other stuff. So you're going to have dry mouth, drowsiness, sedation, rebound hypertension, black sore tongue, and leukopenia. So because you have the leukopenia, you're going to monitor the white blood count. Of course, you're going to watch for hypertension, and you're going to notify the doctor for anything else besides for these side effects. And then just a side point, because they're essentially acting and they affect the brain, something like guanfacine could also be used cognitive enhancing medication, so it could also be used for, let's say, ADHD and something like that, but that we'll discuss later. Beta blockers. So beta receptors bind to epinephrine. Beta blockers do is that they block them from binding to epinephrine. So it has the opposite effect of a fight and flight. So basically it slows the heart rate down, etc. They all end in OLOL. A hint to remember this is that beta blocker has 2 B's, and there's 2 O's and 2 L's. So there are 2 categories, is beta 1 and beta 2. The beta 1 specifically targets the heart and kidney, and beta 2 specifically targets the lungs, GI, etc. So a hint to remember this is you have 1 heart and 2 lungs. Beta 1 includes metoprolol, atenolol. Beta 2 includes propranolol, nadolol, and labetalol. Contraindications: if a patient has an AV block or sinus bradycardia. Contraindications for beta 2, because it has to do with the lungs, or someone with asthma, bronchospasm, heart failure. Just know that a beta 2 would be contraindicated with someone with a lung condition like asthma, etc. Some side effects are bradycardia, nasal stuffness, AV block, and bronchospasm. You should note that you want to hold the medication if the systolic blood pressure is less than 100 or the pulse is less than 60. Vasodilators, so these include nitroglycerin, enalapril, nitrocrucide, and hydralazine. Some side effects: it looks like the regular side effects of blood pressure medication, headache, dizziness, hypotension, and the next one, cyanide toxicity. What they do is kind of self-explanatory. Vasodilate, they just dilate the blood vessels, so it lowers the blood pressure. Precautions are patients with renal and hepatic diseases, older adults, and electrolyte imbalances. Cardiac glycoside. It increases the force of contraction and slows the conduction. The medication in this group is digoxin. You should really know this. They like to test on this. It interacts with loop and thiazide diuretics, which increases the risk for hypokalemia. Side effects are bradycardia, hypokalemia, and digoxin toxicity. What I would know is digoxin toxicity. This includes GI effects and CNS effects. For GI effects, you would have nausea, vomiting, ab pain, anorexia. And for CNS effects, you'd have fatigue, weakness, diplopia, halos around the eyes, and blurred vision. The therapeutic level that you want to maintain is 0.8 to 2. You should know that also. You want to assess the pulse for 1 minute before giving the medication. If it's less than 60, you want to hold and tell the healthcare provider. If someone is in toxicity, you want to stop giving the medication. And if they're in arrhythmia, you want to give them Pentoin. And if they have bradycardia, you want to give them atropine. So you're basically treating the symptom. Antianginal. So these are used to treat angina, which is basically severe chest pain. The medication for this class is nitrates. You should know this one also. It comes in a few different forms: sublingual, transdermal patch, sustained release tablets, and ointments. It's contraindicated in head injury and for people taking erectile dysfunction medication. Some side effects are headache, orthostatic hypertension, reflex tachycardia, and tolerance. These are instructions for taking it. For sublingual, you want to take it and then you want to rest for 5 minutes. If the pain is not relieved, you want to call 911 and then take a second tablet. You could take up to 3 tablets and wait 5 minutes between each one. Also, you want to keep it in a dark container. Do not shake it. You want to replace the tablets every 6 months. You want to wear a medical alert ID. It could also be used prophylactically, like 5-10 minutes before you're exercising. So that's for the sublingual. For the patch, you want to rotate the skin sites. It could be worn for 12-14 hours, and then you want to remove it. For the ointment, you want to wear gloves before putting on. Do not massage it or rub it in. You want to apply to an area with no hair, and you want to cover that area. Antidysrhythmic agents. They're classified according to the electrical conduction of the heart. There's class 1 to 4. Here are just some basics. We're going to get in more detail when we actually talk about the dysrhythmia. Adenosine, it slows the conduction through the AV node. It's for SVT. Some side effects are flushing, nausea, bronchospasm, and a prolonged asystole. You want to give a rapid IV push and flush immediately with normal saline. Next one, amiodarone. It's for VFib and unstable VTEC. Some side effects are bradycardia, cardiogenic shock, and pulmonary disorders. Do not give this with heparin, and you want to monitor for respiratory complications. And the last one is atropine. It increases the heart rate for bradycardia. You want to monitor dry mouth, blurred vision, photophobia, urinary tension, and constipation. Antilipidemics. These lower the LDL, they increase the HDL, which you want. You have to use them with a diet change, exercise, and weight control. Remember, do not use these in pregnancy, and you want to caution with renal dysfunction. Some side effects are muscle aches, rhabdomyolysis, peripheral neuropathy, and hepatotoxicity. You want to take all the medications in the evening. You want to monitor the renal and liver labs. You want to have a low-fat, high-fiber diet. 2 categories under this are statins, the antistatins, that one's easy, like atorvastatin, simvastatin, fluvastatin. They have a lot of drug interactions, so if you see a question and statins on it and it asks if there's interaction, it's probably with that. You want to caution with warfarin, and do not eat with grapefruit juice. Cholesterol absorption inhibitors are the next category. This includes ezetimibe. You want to take these 2 hours before and 4 hours after another anti-lipid drug. And last but not least, you want to stay tuned for part 4B so you could like and subscribe, and I will continue the medications in the next video.